Okay, thank you so much. Now we're going to start this very interesting session beyond hair transplant, robotics, regeneration, and none other than Dr. Kulakarna. She's going to talk on the first talk, scar reconstruction with hair transplant, grafting, and my regenerative protocol.
Okay. Thank you so much for your kind invitation. Okay, good afternoon, everyone. Now, I'm going to start the first topic today about scar reconstruction. Most people think about hair restoration surgery as to correct the baldness in male. But however, the hair restoration or hair transplantation also play a very significant role in doing the scar revisions. I have no conflict of interest to declare. Okay. Okay. Actually, what we deal mostly is alopecia scars, which can be from many causes. The alopecia scars we refer to the hair bearing part, for example, scalp hair, beard hair, eyebrow, hairline, and blah blah whatever. The common problem may comes from many factors. For example, cicatricial alopecia we see a lot in our practice, from trauma, from accident, from burn. And lately, we see much of the cases from aesthetic surgery, including the facelift scar or other cosmetic facial surgeries. This is an example of the burn scar. You can see that the hair bearing part has been missing. It is a gap. There is no viable follicles because of the trauma caused apoptotic change of the follicle cell. So there will be no follicle cell. Our duty is to put more or induce new follicle cell into these scars. This is also an example of the acid or chemical burns. We see a lot of people who had tattoo on the eyebrows and they don't like the tattoo, they go to take it out. Sometimes they use the acid to remove the tattoo and end up with the acid burn scar like this. This is some of the cases from the hair products. For example, bleach products. It can also have a burn effects onto the scalps. Okay. This is also the scar from mesotherapy, which is very popular. The doctors inject some of the solutions to induce the hair. However, sometimes the patient has reactions and they lose the hair. And this is also the cicatricial alopecia, which is actually, it is not an indication for hair transplantation unless it is non-reactive. Okay, a surgical option to manage the scar. In the past, we are dealing with the more aggressive surgery, for example, serial excision of the bald patch, sometimes removing with the flap surgeries to cover with the alopecia patch, or sometimes with the skin flap. But nowadays, we are focusing on the hair transplant surgeries. Since 1940s, we find that the hair follicle cells have the potential of healing process. So when you put the follicles in the alopecia scar, it is not just replace the viable follicular cells, but you promote the healing properties of the skin at the surrounding tissues. And there are a lot of papers later that confirm of the potential healing process of the hair follicular units. So the hair transplantation, nowadays, this is the modern era of hair transplantation. We only do the follicular unit hair transplantation, and the procedure is minimal invasive. You can also use only the local anesthetics. You don't have to put the patient in general anesthetics. And you can do more than one time until you get the satisfied result. The result will be natural look and less time for recovery. The safe donor zone is the back of the head. You can also use the FUE or FUT technique to transfer the follicles. So concept of grafting, like I said, not just only put the follicle cell into the tissues, but you also put the cells, viable stem cells, to promote the healing property of the tissues around there. Okay, and modern hair transplantation can be divided into two main techniques. We call FUT or follicular unit transplantation or the strip harvesting technique, and the other one is follicular unit extraction or to take it out one by one. And recently, the technique becomes beyond just ordinary, follicular unit excision or extraction. We can also do the extraction without shaving, and we can offer the long hair transplantation, so the patient will be even quicker recovery. This is a picture of this is my own device I created with some engineers to take a long hair FUE, and you can see that the patient doesn't have to clip the hairs, doesn't have to shave the hair. And the grafts that you get will be long hair shaft that you can use instantly. And the implantation process, now we have many devices to help us. This is implanters that allowed us to do the procedure with very quick and very good results. And sometimes we get the hair from another part of the body. For example, the hair under the chin or facial hairs. This is the second best donor area apart from the scalp hairs. And you can see that the healing process from the beard hair when we transfer is amazingly, healing very good. And special consideration when we're doing hair transplantation on burn or scar alopecia. Sometimes to achieve the maximum satisfaction, you require more than one session. You cannot guarantee with the patient that everything will be done in one go. You have to tell them that sometimes we need more than one session until you get the satisfaction results. Because the scar tissue is not a normal tissue, the vascular supply is less than normal tissue, so you cannot expect a very high success rate. And when you're doing the scar alopecia, you put the grafts in less density to ensure that you have some space for the vascularizations, and try to get the psychological support, like you induce least pain, because these kind of patients have experienced very bad from the accident or trauma or from the scar. This is the example of the burn wounds on the face. This kind of patient, you may think that she can do a tattoo, she can do a pencils lining. However, if you meet with the real patient, you realize that the tattoo is not working on this kind of skin. And the pencils is not, really stick to the skin. When you do the pencil, it wear off very soon. So hair transplantation is also an option, and it is successful. This is the case of acid burn. We put some hair grafts on that, and you can see that the success rate is good. However, it's not 100%. The patient probably have to do a second round to get the maximum result. This I get it from the textbook, because our local Thai people, we don't really have very big beard. And you can see that the hair, when transferred to beard, it can camouflage the major part of the scar on his face. This is the acid burns, and she loses her right ears because of this. So during her ear reconstruction, she doesn't have enough hair to cover her right side ear. So then we do the FUT or strip harvesting technique and put the hair graft onto these scars. And it works quite well, so she has some volume to obscure her right ear. And this is some example of burn scar as well, and she also lost some of hairlines and the eyebrow. So then we do the eyebrow transplantation and hair transplantation in one go. This is an example of blast surgery. He had the scalp, he experienced the explosion and he lost his scalp. So he had a cranioplasty and covered with the free tissue transfer. This is radial forearm prefab. And you can take some aware of the pedicles when you do a hair transplantation and use the very minimum lidocaines and adrenalines in the anesthetics. However, this patient is responsive very well with the hair transplantation. This is the correction of the scar facelift here. Even the FUT scar from hair transplantation itself, we can do FUE surgery onto those scars and camouflage. This is the effect of 2 times brow lifting with the stretching scars. We can also do the hair transplantations here, correction of the sideburns. And this is the pubic hair transfer to camouflage the FUT scar. It also works, but not really effective comparing to the scalp hair. An additional regenerative protocol to improve the scar survival, we include laser, adjuvant therapy, hormones, growth factors, cytokines, and cells therapy. Hair follicle itself is a cell therapy. However, we can also top up with some fat tissue transfer to get more vascular viable into the scar tissues. I usually use the mechanical separations of the fat stem cells and inject it back to the scar to enhance the success rate. This is a cicatricial alopecia, which is non-reactive for more than 5 years. We inject the fat 3 months before the surgery and then put the hair transplantation, and it is success. This is also the scar from fat harvesting from belly and then do the fat injection into the scalp, the scar before hair transplant. And you can see that the hair transplantation is quite successful after the fat injections.
2 minutes left.
Apart from that, the lasers also induce some regenerative protocol. There are a lot of laser, a fractional laser that can induce the wound healing. For example, Urban Yak, fractional 1550 thulium laser, CO2 needle arrival or microneedlings. And you can also add on some specific hormones, for example, thyroid, vitamin D, and growth factors. And cell therapy is also promising in the future. I have no time to talk about the cell therapy, but I think you have heard a lot about the cells from other rooms. And the future of hair transplantation, maybe it's just only one cell, and you can grow it in a farm. We call it hair farm. Maybe we can grow the hairs on the nude mice, and then we harvest back from the nude mice and grow it back to the human skin. This is the future. A take-home message. The follicular unit hair transplantation is a good selection method to correct the alopecia scar. It is quick recovery, less pain than the other surgical procedure. The adjuvant regenerative protocol has been proven to be beneficial. One session of correction cannot be guaranteed to the patient. Sometimes we need a multiple session to get the maximum satisfaction. Thank you so much, and I would like to announce the AHS meeting this year. On August this year, we will have the life surgery workshop, which is in Chiang Mai, the northern part of Thailand. Thank you for your attention.
Okay, thank you very much for your excellent lecture. So the next speaker is Dr. Desai. Dr. Desai is a very famous plastic surgery from India. The floor is yours, Dr. Desai.
Thank you so much, Dr. Chucha, and it's been so many years now in IMCAS Asia to always have to co-chair with you. It's always such an honor and pleasure. Well, I have 24 years of experience into hair restoration, whether it's transplant, regenerative, and recently regenerative medicine coming into hair is of special interest. While it's loading, I don't think it's taking so much time. I have no conflict of interest. Start. Okay, it's processing. So I have no conflict of interest. What I'm going to, okay. I'm going to be, of course, we know about alopecia being a big problem and increasing day to day because of the inflammation, because of the lifestyle. We know this. So like I said, 24 years of experience doing this. Growth factors, we all are aware about growth factors for many, many years, whether they are plant-based, animal-based growth factors, or they are lab-made, recombinant DNA technology. They all have great uses from fibroblast-derived growth factors, keratinocyte, interleukin, platelet-derived growth factors, very popular with PRP, interleukin growth factors. It started again by itself. Okay. And TGF-beta. So all these and many more growth factors we are aware about to promote hair growth. They all work at different levels. But one thing about them, they do not become part of cells just like exosomes do. They attach to receptors. From that, they will give the signal, the transduction signal, the relay proteins, and that will cause the end action of the cell, which will help for cellular growth and proliferation. So this is a brief diagram where each of the growth factor, at what level does it act and what does it do, okay? So we are aware about this. Now, you have to traditionally search for these growth factors, you need them from animal sources, plant sources, human sources. So you have to keep screening the donors, you have to keep getting more and more source, you have to keep screening the growth factors. How do you increase the production? How do you make sure that you're not going to have problems in the future, allergic reactions? How do you make sure that your donors are adequately screened? So that is where the future comes. Plus, so because of hair loss being multi-dimensional, there are so many things we are still learning. It's not just genetic, it's not just testosterone, it's inflammation, it's reactive oxidative stress. So it's a lot of molecular complexity which we see, okay, from genetic to androgens to dynamic and cellular networks. So you have to have treatment which cover all these pathways. So what are the growth activating pathways? We knew about WNT beta catenin pathway for many, many years. HHH pathway, something which has been researched. I think the WNT has been the most researched pathway. PI3-AKT, which again is for DP, inductivity and regeneration, has been researched. The BMP, now recently JAK inhibitor, JAK pathway has been talked about. Then we have the MAPK factors, again for morphogenesis, and the Notch pathway. So this is some of the pathways that I have read about and we've seen some evidence. But every year we come across more and more new pathways, okay? Some of them are activating, some are inhibitory, and some are regulatory pathways, okay? So let's see, if you're driving a car, so you have the handbrake. Yes, you put your in the first gear, second gear, third gear, or in the reverse. But you have something, the handbrake, which is your BMP pathway. So if you are, till today, we were only stimulating. We were only using WNT stimulators, SHH, we were decreasing the inhibitors, okay, JAK inhibitors, everything. But we were not talking about the regulatory pathway, which is the handbrake. What if the handbrake is pulled up? So hence you had a plateau of results. Then you had deterioration of result over time, and you could not sustain the results continuously, which we all know that once we're giving treatment, we don't get the same results continued, sustained. Maybe in some months, few years, it does change and decrease, and that's where the handbrake phenomenon comes. So this is what happens when you target a single or 2-3 pathways. You need an orchestration and stimulate all the pathways. You need to remove the handbrake, so the regulatory pathway. You need to remove the inhibition. And then only would you get an adequate response, a sustainable response which will continue happening. So this is where our understanding of hair cycles, regenerative, has changed over time. This is where we are. So yes, with this, you will not face the problem of initial improvement, but later on the durability is questionable, and you may not have less, you will have less non-responders, and plateauing will be much later. It won't be in the initial stages of 2-3 months, but maybe over 8 months, 10 months, or even after 1 or 2 years. Okay, that's where we need to shift the thinking, not where what pathway do we activate, but how do we enable the balance. So don't think of it just stimulatory, but removing the inhibitory factors. So it's like an engineered orchestration of the entire process. You release a handbrake and you do. So conventional therapies, all of them work in complex ways, most of them. Some of them we know the ways how they work. Minoxidil, for example, has so many different ways how it acts. It just doesn't increase the anagen phase. It just doesn't improve the blood supply, but it also stimulates the WNT beta-catenin pathway. But it does not affect any of the inhibitory or this. So hence the shift of the core principle is harmonization and dealing with multiple pathways. This is how the pathways will work at the cellular level. So you can see from this, you continue stimulating, you remove the inhibitory pathway, the BMP, which is inhibited, and that is how you will get a continuous triple action mechanism, which will help in cellular modeling, which will help in regeneration of the dermopapillary junction, and will give us sustained results, which will continue, okay? Here is the use of the so-called biomimetic peptides, which are nothing but the synthetic, lab-engineered short chains of amino acids replicating the function, replicating the structure of the growth factors. They actually occur, they actually mimic the activity of the naturally occurring growth factors which are required. Some of them, there are many more being researched day in, day out, but some of them are out here which are very useful. SH polypeptide 9, which is actually mimicking vascular endothelial growth factor to induce angiogenesis. SH polypeptide 1, which is actually inducing the dermofibroblast mitogen. Oligopeptide, with anagen phase stimulator. Copper tripeptide has been spoken about. You open up anywhere, Insta, and everybody's talking about copper tripeptide, especially for hair and even for skin and its variants. So it inhibits alpha reductase, polypeptide 3, which increase the hair survival rate by following the cytotoxic insult. Oligopeptide, the thymosin, again a very much talked about peptide, okay, stimulates the stem cells. Some of them which are very useful for hair growth. But this solution, the one which I use, do contain these biomimetic peptides. Along with that, a few of the amino acids which are essential like methionine and cysteine, some calcium pantonate, biotin, which we again know is useful, coenzymes like ionositol, white nitroxyden, linoleic acid, basically to nourishes the scalp barrier. And linoleic acid is also used topically. We know it was used to stimulate the blood supply. So all these are mixed to a certain extent. This is one of the formulation I'm telling you. There are different formulations. Some of them even contain zinc, magnesium. Some also contain they are also mixed with some growth factors. Recently, I came across a couple of formulations which also contain some exosomes in it. So this is how it's been done, but the core element is the biomimetic peptides. The core element is important, okay? So this is a molecular mapping. I'm not going into detail. To explain this will take, but basically it is targeting the pathways, the 7-8 pathways which I have shown you, okay? So it has the BMP pathway modulation by SH polypeptide 13, which is very important. Receptor specific targeting is by polypeptide 62, polypeptide 4. Focus signaling is by the polypeptide 3. And hence this multiple pathway which is acting, okay? Again, like I said, some of where each of the polypeptide acting on which pathway, majority, okay? So yeah, we want to activate WNT, SHH, PI, AKT, JAK. JAK we want to regulate, Notch, MPQ we want to regulate, and BMP is the inhibitory. We want to inhibit. We want to remove that pathway completely. Each of them where it is acting, it's been put up out here, okay? A study which was done with biopsies taken, which actually showed the recovery of oxidative stress using the formulation. I'm just saying, I'm not using any trade names here. Like I said, there are many formulations available even in the out here. So you decide which you think works better after studying each polypeptide, how it works. So here it shows that the H2O2 challenge the oxidative stress, the recovery is much faster. The type of collagen synthesis is much more after using the peptides. The wound healing is significantly accelerated. Okay, these are studies which have already been done. The papers which show this study. So where do you use them? All kind of patterned hair loss, hereditary, so-called genetic, androgenic, male-female pattern, effluvium, especially you can use it in chronic telogen effluvium, partly in other alopecias also has been tried, but the first indications are the most important ones. How to use it typically, obviously, like any mesotherapy product, clean your scalp, wash it thoroughly, do not apply any kind of products at least 48 hours before.
2 more minutes.
Yes. In order to increase the penetration, preferred method of use, sometimes controversial depending upon what your country allows. In India, we cannot use it, it's only for topical application. A lot of doctors use it with microneedling, maybe some also inject it, but on paper, legally, it's only be allowed to use by topical application, okay? So you may use a derma roller, derma pen, derma stamp, bottle rollers, or you may inject, okay? We all aware about this. So let me not go into detail of that, okay? Then, yes, this is with derma pen, okay? Then how many sessions? 4 is a bare minimum. 6 to 10 sessions average is recommended at a gap of 15 days, so twice in a month. You continue doing this till you attain optimum results, maybe 6 sessions or 8 sessions. Then you could do it monthly, and then gradually you shift to a 3-month protocol as a maintenance, okay, classically. And this works very well. This works very well. Post-treatment, no exercise for 24 hours. Do not wash your hair for a few hours, around 6 to 8 hours. Do not apply any products for a few hours. Do not touch the scalp. Basic protocols. Advantages: short 10-minute procedure can be performed by your nurse or assistant. Does not require the surgeon to do it. No blood requirement. Fast, predictable results. Multiple pathway. Minimal or practically negligible pain and no side effects. No rejection, no allergies. The results, yes, I mean everybody will show you before and after, but yes, please do try them, they work, biomimetic peptides. With this, I'll like to invite everybody to come to Goa. Please do join us. We have an association with many, with IMCAS and so many other societies, Dubai Derma, DASIL, IDA, Kulkida, 5cc, so many more. This is 19 to 21st of July. Many more, a lot of topics. Longevity has been discussed there. Hyperbaric oxygen. We had our first leg last year. This is the only Indian conference which is derma, plastic, and gynecologists all combined together. Thank you so much. Thank you. Thank you.
Okay, thank you very much. We will have all answer at the end. Okay, so please keep your question. Okay, the next speaker is Professor Lee. He is a plastic surgery from South Korea. I don't think he needs any introduction. Okay, he is a superstar. Dr. Lee, please.
Good afternoon, everybody. I'm Dr. Young-Sub Lee from South Korea, a plastic surgeon. So today I'm talking about is it possible to prevent the late complication after hair transplantation in androgyny alopecia? So after hair transplantation is before Thai professor explained about even though cicatricial alopecia is hair transplantation and they make a good result. So most of the time is now is after hair transplantation, patient is very happy. And then 1 year later is over 50 cases happening, shedding and thinning. So they are disappointed. So how can we prevent these things? So why hair is thinning returned despite a successful restoration? I will explain each of each. So the first possibility is root case. Transplanted hair is well survival, but its problem is not transplanted hair. Previous hair still is attacked by the DHT. So that's going to be thinning, shedding. So previous hair is follicular aging. So another one is cellular is trigger. So chronic is microinflammation. That one is maker is hair shedding again because its environment is not inflammation is a condition is easily hair shedding. Also, is lesser supply of the blood supply is skin is hair is much thinner. Last one is management gap. After treatment, we stopped the medication, we stopped the treatment, so eventually previous hair is shedding. So is a little bit summary. Thinning after the 1 year is not is a failed surgery because is most problem is previous hair is a problem. So how can we intervene? Intervene is before progressive miniaturation, a bigger eligible. But therapeutic is a target is a DHT suppression. Second is anti-inflammatory modulation. Also is a vascular support. Also the more popular regeneration, even though hair cycle regulation. That is our therapeutic target. This is general, right? General, not only hair transplantation case. So among the is there are six different is kind of the treatment way. First is most common is finasteride and dutasteride, and second is minoxidil. Also is PLP and exosome therapy and microneedling or is low level laser. Is among the many is treatment. Nowadays, I'm gather and make a graph is which article is more is rapidly is increase the number of the articles. One of the is article is treatment of the minoxidil. The minoxidil, the reason why minoxidil is not only ATP sensitive potassium channel activation, and then eventually is a blood vessel is widening, is more blood circulation. But nowadays we know more about the function of the minoxidil. This one is vascular endothelial growth factor is more promoting. That's why it's more angiogenesis, meaning it's more circulation. And then minoxidil is a make. That's why is we popularly using is minoxidil. One of the is our chair is father of the minoxidil in Thailand. If you have any question, just ask him, not me. Okay, I'm surgeon. So yeah. So another one is among the is a treatment. I little bit focus about the exosome because exosome is a rising star. So a exosome is we can exosome can do is proven pathway is want and beta catenin is improve the condition. Also exosome is vascular rebuilding, so more blood circulation. That's why last few years, from 4-5 years until now, is very rapidly increased the number of articles. Okay, is why is exosome essential post-surgery? We can think about three things. One is immediately inflammatory is control. Second is maximize the great survival rate. Also is preserving, is preventing the surgical shock, is preventing the by exosome. That's why is exosome is nowadays is popularly using for after hair transplantation. So summary of the action of the mechanism of exosome is using the hair transplantation. So first is maker is reduction of the inflammation. Second is restore of the stem cell dehi. Third is activate the dermal, activated dominant is follicle. Fourth is a prominent angiogenesis. Finally, increase the hair thickness. So this one can prevent the after hair transplantation, previous hair is condition is improve, also is prevent the hair loss, also hair shedding, also is hair thinning. That's why I introduce. Usually my protocol is microneedling, but is depth is 0.3. But I prefer using the 42 pins because it's more pins, more delivery. Always I explain about the exosome, skin or hair is I like to introduce the exosome tattooing. So 16 needle compared to 16 and 42 pins needle, which one is more delivery of the exosome? So I love the 42 pins. Also is I don't want to depth is 1 millimeter, 2 millimeter, 0.3. I will show is why. Also is many people still is using exosome as an injection, but I don't want. So that's why I'm try one side is M-shaped baldness. I try one side is injection, one side is microneedling 0.3. So before, after is which one is the injection part? Type A is the injection. Lesser growing new hair. Type B is microneedling, 0.3 only. So why? We think about that. So fortunately, I find one of the article. this article, the microneedling with exosome enhanced the delivery directly to the hair follicle, stem cell, and the dermal papilla. Because we injection with, maybe we inject 3 millimeter, 4 millimeter, very short needle. Also, it does not cover 2 layers. Sometimes a little bit deeper, sometimes a little bit superficially, sometimes deeper. So microneedling, evenly delivery, wanted depth. 0.3, and then diffusion cover the hair follicle stem cell, also dermal papilla. That's why microneedling is better than injection. Okay, not only legal problem. So this case, this guy says after 6 months later, take a photo. He's very happy. He's Caucasian, very happy. Yeah, I'm jealous of him. I'm jealous. But he's 1 year later, he's so sad. He is a plastic surgeon also, UK plastic surgeon. But he is not happy. And we tried to, this guy, we tried to exosome. Only 0.3, one-time treatment, and then 1 month later. 21% increase the density, also 21% increase the thickness, only 1 month. Okay, 6 months, 1 year, 1 month later, 1.11 years, right? Yeah, dramatic. So only microneedling, no pain, no recovery time, nothing. But it's dramatic, okay? But another is a question. Treatment protocol is the first week, first month I try to every week. And then next month is I try 2 weeks interval, after that once a month. That is my protocol. But it's not only this, interesting things, this one is me. He is, this guy is only 1 treatment and 1 month later. This guy is, not 1 month, make a mistake, is this guy is 6 months later, 5-time treatment. It's me. Why? He is 74 years old guy, me 68. Why different? I try 4 times more than him. The reason why? Is my scalp don't like the exosome? I don't think so. The reason this one, usually baldness alopecia is a fresh case, is also is young people. Still they have dormant is hair follicle. They sleep. So exosome and PLP can make a wake up. So immediately growing up. For me, is a genetic cousin, also is quite long, last 20 years, is no hair in here. So I don't have even though sleeping hair follicle, no hair follicle. So between the PLP and exosome is different one is exosome is can make a new hair follicle. PLP is cannot make a new hair follicle. Only wake up the hair follicle. So that's why a little bit different.
1 more minute.
Yes. So is take-home message is during the after hair transplantation, we have to focus only not only transplanted hair. We have to focus about the previous hair. So keep maker improve the condition. That is very important. So that don't forget about maybe patient is complaining, crying something, but is don't think about yourself. I make her my surgery is hair transplantation is fails. No. Okay, so I think this is last slide. Thank you so much. Thank you.
Okay, thank you very much, Professor Lee, for your excellent lecture. The next speaker is Dr. Teddy from China.
So good morning, everyone. Like I'm local from Thailand, but now I'm pursuing my PhD and practice in Shanghai, China. So today I will talk about the advanced research in the clinical application on the robotics hair transplant. Our team not promote the device, but discuss how the robotic may support the precision and standardized and safety in FUE in hair transplantations. China alone, over 250 million people is suffer from the hair loss. It means 1 in every 6 individuals in affects. And especially the young adult, not the only cosmetic procedure, it also involve the lifestyle and the quality of life too. Before we discuss about the treatment, we have to know how to diagnose it. And then these alopecia, they separate for the scarring and non-scarring alopecia. The scarring alopecia may cause the permanent follicular damage, so the robotic can help the procedure, but it cannot replace the diagnosis and treat the diseases. So the treatment should depend on the diagnosis and the state, the scalp and care medication help the early process diseases. We can give immediate improvement that put on your head, right? And the transplantation is useful when the hair loss stable and the donor area adequate. So the hair transplantation is part of the treatment strategy. It's not the first option for every patient, for sure. So the two of the surgical technique is follicular unit transplantation, FUT, remove for the shape and the scalp and stab into the follicular units, right? But after that, you will see the long scar. Follicular units extraction, FUE, separate by unit, and usually very less the scar. And however, the technique demanding because the surgeon must control angle, depth, direction, and the scattering of many grafts. So the transplantation have gradually became less invasive and more precise. Early punch graft was followed by the donor demonstratory and FUT and FUE. Robotic, another step is the evolutions. The biological principle is still same, but the imaging planning and robotic motivation improve in consistency. So although the FUE in the widely used several pain that remain, the training the experiences have to treat many years. So not easy to train the hair transplant doctor. The technical quality may vary between the center. This is not the same every center, I'm for sure. The question is how they make the FUE more the standard and more easy to learn and more efficient. So the robotics hair transplantation start early system such as the ushers in the stage. Later, the robotic system in the clinic used in China. More recently, domestic system had also been developed, and this general move from the manual extraction toward an image guide, more the standardized FUE. Artists and the example to how the robotic FUE has involves mainly harvesting. Later versions add the better image, faster harvesting, auto parameter, recipient size planning, and improve the workflow. This suggests that in the future, not only the robot arms, but the whole digital surgical workflow. This slide shows the collaboration between the engineering, clinician, and clinical needs. The important point, the translating need to into the engineering designs. They need to include the follicular recognition, punch trajectory, planning, and donor stabilization. So the agent had the characteristic workflow efficiency and reduce operative variability. So you can see this developed roadmap. The first generation focused on robotic extract. The second Gen it means the inversion and implantation. The third generation moved toward the shape and procedure. They are promising direction, but they should still the validation clinical outcome too. So, robotic FUE combines several AI components. Vision help recognize the follicle. Planning helps estimate the angle, depth, and trajectory, three-dimension modelings, and may support decision makings. And robotic arm then perform the repeat micropuncture. But the key message is the simple, how to say, you have to have the quality graph too. So hardware design important in FUE. Scalp tension can affect the image quality. Everybody knows that. The punch angle, follicular alignment, and transaction risk. And stable tension, also the punch needle may improve the consistency. So the software innovation focus on recognition the follicle and the predicting, and this thing use the under the skin. Everybody don't know because we just see in the skin. We don't know what it with left side, right side, or something. But the infrared will know more than that. So visible hair shaft does not always match the true follicular direction. If the fund follow the wrong path, transition can occur. So trajectory prediction may help improve extraction precision for sure. This helps to identify the hair, the single hair or multiple hair follicular units. This measure critically because the graph have the different rules, right? If you use like a single graph, you can use a hairline for make it natural, right? But the multiple graph you should be used in the mid scalp or in the crowns. So better recognitions may support the better harvesting and graph allocations. So this slide shows the real-time robotic arm patch adjustment. The eyes in the hand system mean the camera moves close to the robotic arms. The scalp is not the static during surgery. Tension, curvature, bleeding, and the small movement can change the fields. Real-time feedback, it helps adjustment trajectory and improved consistency. This just compare, report from the US and the China to increase the speed, translation rate, and discharge rate and tensor size. So however, we should interpret this number carefully. They depend on the patient selections, hair characteristic, operator experience, and device setting and measurement methods. The goal is not like it's the better, but how to show the proof, what is faster and the you. And the same graph you can see an ideal is reducing the comorbid donor trauma. One FUE wound is small, but the thousand of the wound can create the meaningful total wound area. In this example, a small punch diameters estimate to reduce the donor wound area by 23.4%, but the small wound must still balance with the graft quality. This is an important thing, the graft quality, and the transaction risk. So left side is the old version, and right side is the new version. The new system also report the faster puncher, the speed higher than made, reduce the procedure time in the fatigue. Not only for the patient fatigue, the surgeon also fatigue too. Everybody is so tired, right? And however, this the speed alone is not the end point. They must to have the quality of the graft too. So you can see like this is immediately after we did the like puncture. And this the picture after take the day 4. The success that the small wound relatively uniform the extraction, but the photo alone is not enough scientific evaluation. In the future, our team will did the measure the wound area, erythema, casting, pain healing time, and static focusation, and donor visibility and the scarring to test too. You can see this scalp from the machine. I'm pretty sure it's better than our resident, and better than in our fellow in first year. You see the a beautiful graph. And therefore, the graph intensity, transaction, dehydration, handling injury, and several after implant are the key, the endpoints. So the summarize in robotic hair transplantation is evolution in FUE. Its value is not speed. The standardization and donor management, AI assistant image may help recognitions, planning, and depth controls. But the diagnosis patient is very important, and select the patient design, complication management remain have to do by the physicians. Again, robot not help us. Robot help us, but cannot then the surgeon. You have to know that. For the last thing, I just wanna welcome everybody to our IMCAR China. It will be in August, right? And the last thing in our OPAC in 2026 be in the Shanghai 2 in October. You are very welcome everybody to join us. And the last thing, I have to thank you, our team in plastic surgery team and dermatology team, and thank you IMCAR to give me the opportunity to share our works and the research. And thank you the audience to listen. Thank you so much. Thank you. 谢谢 and ขอบคุณมากครับ
Thank you, Dr. Tek Day, for your very informative lecture. So now is the time for the Q&A section. And any comment? Yes, please, on the microphone.
I have a question to Dr. Teddy. Yeah, I'm asking you for the robotic hair transplantation. What kind of the style, the hairstyle is suitable, or all style, and how about the survival rate of the hair follicles via the manual? You use your hand.
Okay, the manual at first you have to see the surgeon. I mean, if seriously, if the resident did it, maybe not success rate is not that much, but more, maybe like a professor or something, maybe success rate high. But the for the robotics, success rate around the 94%. Yep. All kind of, okay, the healthy hair, the healthy donors. Please.
Please, on the microphone, please.
My question is, does it help in implantation also? Like we just saw the extraction aspect of it, but does the robotic assisted hair transplant, is there any provision for implantation? Does it help in implantation? Like, you know, when we are, I just saw the extraction aspect of the FUE, right?
Yep.
But does the robotic hair transplant assist in implantation also?
Yeah.
It does?
Yes.
Do you
But how to say, it will in the how to say, in the lab, not in the the data yet. So that's why.
Okay.
Yeah.
So, but end to end, does it help in, you know, like?
Oh, for example, like that, okay, it helps surgeons just for the how to we cut it. I mean, like we will put the sensitizer first, and after that, the robot will help us to have the hole, and then after that, the surgeon will put the hair by themselves.
Got it.
Yeah,
Thank
but interestingly, it means the robot have eye, right? They will detect the more than, you know, like one graph maybe have 3 hair, 4 hairs or something. They will send, I mean, they will calculate first, and after that the robot will find the more hair first. Yeah, so that's why it can be less the a trauma. Yep.
But the implantation needs to be done by the technician? Like,
Yeah, no, you have to buy the doctor. I already.
doctor?
Yeah.
Yeah.
The doctor have to do.
Has to implant it, right?
Yeah.
It will just help you create a grid and, you know, tell you where you have to place which grafts.
Yeah.
Okay.
But in the future, we will try to use robot do in the future.
Okay.
Yeah.
Cool. Thank you so much.
Yeah, thank you.
On the same note, I have a few questions for you.
Yep, please.
You claim the punch size is smaller, right?
Yep, sure.
As compared to artists. Now, artists, another problem was that it could not extract from the sides or where the hair is angular. So can this robot do that too?
Seriously, Professor.
What about the beard, body, sides? Is it possible to extract?
Seriously, if for the beard, right? If they have the more the like skin very thick like that, it's okay. But not for the like thin skin.
And the sides?
These two, yeah. Only these two, yeah. I'm
Okay.
not that good.
Okay. You mentioned another problem with artists. The transaction rate was higher than normal FUE, what we do. You also mentioned around 7%.
Yep.
Is that total transaction or partial transaction?
Oh, this question, how to say? Just like the calculate, I have to ask my team first. So this question. Yeah.
Okay. Because another problem with artists was the partial transaction.
Yeah.
A lot of partial transaction.
Yeah.
Third, of course, like you already answered, it doesn't implant.
Yep.
But I think the new model of artists, the 9X, I think, it also implants
In the future.
in the future.
Yeah, because like
Developing.
yeah, developing, right? Because the software, seriously, I just cut off some part, and we will publication soon. I just show some part. Yeah.
Okay. Second, the artist could not implant in temples, very low angles. That's another problem with the artists. So,
We killed the problem already.
which will be.
But I cannot say that because like I have to scientific proof. So that's why I said that like. Yeah. If I said like that, maybe some people think, oh, I can do like that, the secret.
And
Yeah,
how
yeah.
many grafts can it extract per hour?
Per hour, seriously, right now it's 2,700.
Okay.
Yep.
With the new artists, they have the suction in way, where the artist makes the hole, and the suction takes the graft. So you don't need human to extract.
Yep.
So is the same technology, or you have to pull out by humans?
This also the how to say this secret. I mean like I will
But
tell
how
you.
do you pull the graft? There's no secret there.
I mean the
if you punch-
hold the graph by physicians. I hold the graph by the doctor, but the
By the doctor, okay.
yeah, the doctor. But in the how to say the generation 4, we did more. My professor said, Teddy, don't say too much. I will say it by myself.
But that can't be a secret, because does it take the graft? So you said the technician has to.
Yeah. Sure. So that's why I said it.
Actually, artist does not have the technology. Artist bought over NeoGraft, which had the suction. So they just added that to it. They only bought NeoGraft just to get the suction, the patented. They only did that to buy, only for that reason. And they've added that to the new machine, the 9X,
okay.
I think, 9X. But yes, I think, thank you so much, very interesting. Let's see with the future. As of today, a lot of us feel skeptical about robotic, because we extract beard, we extract body.
Yeah. Maybe we publish together. So that's why now I have to quiet first. Begin the publication
We
process.
look forward to it more and more in the future.
Yes. Yes, please.
Okay, the last question. The lady in the blue, please.
One last question. This is not for hair transplant. I want to know your experience of exosomes and scarring alopecias. So I want to share one case that I've done. So it was an accident scar, and she's done scalp micropigmentation some 15 years ago. And after 4 sessions of the rose exosomes that are available in India, those ones, we saw new hair growth. She initially told me, please leave out the scarring areas. I would just want to, like postmenopausal woman. So I observed good hair growth in the scarring tissue. But this is for accident scar. Now, like in the discussion, they said like it helps in, neo-regeneration of the scalp follicle. So, but are we supposed to advise it, or your experience with it?
Exosomes, there were papers even published for reversal of graying. But that's not something that you should claim. You should be skeptical about it. But it has been shown to help in a lot of immune and in a lot of scarring alopecias. Lot of papers, lot of results. So there are so many pathways, if you saw what I was talking about, that we are still discovering. We don't know. And that's where all these regenerative therapies are actually working on. So let's see what it is. But it does, you can try it. Yes, it does work.
Okay, thank you very much, everyone. Sorry, the time is up, so you can grab the speaker later. Okay. All the speakers are here or outside the room, because the new section is coming. Thank you, everyone, all the speakers and everyone joining us. Thank you.